Okay, hello, and welcome to our webinar on place-based clinical leadership and everything you ever wanted to know but were afraid to ask. Can't guarantee that by the end of the hour you'll know everything that you need to know, but we'll have a good go at trying to help you work out what place-based clinical leadership is and what we know about it as and we'll call ourselves experts in the room and elsewhere across the globe. My name is Ted Adams. I'm part of Kaleidoscope. I'm a clinician. I'm a clinical director in obstetrics and gynecology in the northwest of the UK, chief clinical information officer, and I've been working with Kaleidoscope since the off. And I'm joined by Karen Kirkham, Alex Gimson, and Mark Hamilton. This is Karen here with me in the studio, and Mark and Alex are out in the wilds of the digital world. You can join in at home, and we'd love you to, by tweeting us on @Kaleidoscope HC and hashtag PBCL. On the screen you can see it says hello@kaleidoscope.healthcare. You can send us an email. We'll grab that email and put up the questions for our panelists to answer. And you can also use the questions tab in the GoToWebinar application as well, and ask us any kind of questions that you want. We've had some put in already, and we're poised and ready to answer them all. When we first started talking about place-based clinical leadership at Kaleidoscope, there was probably less clarity around place-based clinical leadership systems than there is beginning to form now. And certainly over the last few months, as primary care networks have really come on stream, the energy around what place-based means, and particularly what place-based clinical leadership means, has increased. And we've certainly seen a fair few of you who've logged in today are GPs, probably wondering what to do with your newfound role as clinical director of a primary care network. And hopefully we can help you with some of those questions. But when we first started looking at this at Kaleidoscope, we started to try and define what place was. And place in terms of the NHS is very variable. We found that place-based systems could correspond to different geographies. It could have corresponded to an STP, to some CCGs, now to primary care networks. But we didn't really want place to be defined by an organisation or even a geography. If you look further afield than England for place-based care, you might look across the new Severn Bridge, or the old Severn Bridge for that matter, to health boards in Wales, or across the Irish Sea to the health and social care boards in Northern Ireland as well. You could even look across the Atlantic to accountable care organisations and see that clinical leaders are needed in those different geographies and different organisations. I think it was without the benefit of having to write any of the policies that have recently come out, we've been thinking about what place would mean for us. And for me, it really meant what is the care that we should deliver to a citizen within a place, and how can we maximise the healthcare of that citizen. We wanted to get away from the idea that the medical director of a place or a clinical director of a place would be the all-singing, all-dancing knowledge repository and action person. I suspect that Karen's going to talk about trying to avoid heroic leadership, but we wanted to make sure that we looked at avoiding being that single point of failure and that single expert. And I think if we can try and see place-based leadership through the lens of avoiding being that single point of failure, then we'll begin to get a framework through which we can think about becoming a good place-based clinical leader. But that probably means doing something a little bit different. We wrote a blog in HSJ, and in that we suggested that there were 3 areas that you might want to consider, and that is don't expect a job description. We're probably not going to be able to define your job description within the hour, but what we would aim to do is to try and define the areas which you might want to start thinking about in order to deliver what your role will need. Find some new shoes, we said, which I think that translates as really get out there and start thinking about who's in your place. Is there something around the wider determinants of health that you can start thinking about? They're third sector-based organisations that can help you. And then learn together. So, for example, log on to a webinar provided by Kaleidoscope Health and Care, and ask us some questions about how we can help you understand what it is that you want to do. And you can do that by emailing hello@kaleidoscope.healthcare or tweeting with hashtag PBCL or in the questions tab, which is just on your webinar browser. So let me move on to introducing our speakers and beginning to hear from them about what they've got to say about place-based clinical leadership. So as I say, in the room with me, we've got Karen Kirkham. Karen is Deputy Chair of the Dorset CCG and the National Clinical Advisor for Primary Care NHS England. Practicing GP, we were discussing Karen's day at work yesterday where she put a Venflon in, everyone, so very, very impressive.
First time.
And out in digital world, we've got Alex Gimson. Alex is a consultant transplant hepatologist at Cambridge University Hospitals and chair of the Care Clinical Advisory Group at Cambridgeshire and Peterborough STP. And also out in the digital world is Dr. Mark Hamilton, who's the Clinical Director of Surrey Heartland's Integrated Care System. And Mark is a consultant in anaesthetics and ITU at St George's Healthcare Trust. So we've got 4 real clinicians who are all doing leadership jobs, working across places, working across different organisations, who are here to help you answer what we think place-based clinical leadership is. So we'll start with Karen.
Thank you so much. So thought it'd just be helpful just to put a little bit of context for you about my role really in the last 6 years. I've been primarily just a clinical, a GP working clinically for the last 25 years. I'm still working 1 day a week, and I'm senior partner in a pretty stretched practice. I live and work in Weymouth. In the last 6 years, I've had the privilege of working with many other talented clinicians and managers as part of Dorset CCG, became the Assistant Clinical Chair, and had the privilege of leading some work around reconfiguration, starting with acute options for reconfiguration across acute services, and then realising that actually nothing was really possible to be changed in the acute system without thinking about how we grew community and primary care, and so led a piece of work on community redesign, and as part of that, sustainability and transformation of general practice. So for the last couple of years, really starting to embed a culture of joint working in my local system, which is Dorset, which is one of the first wave integrated care systems in the country, and really starting to think about what that vision might look like and how we would start thinking about really this idea about place-based the reality of place-based service provision before primary care networks were really ever really talked about. And so for me, they really set the foundation for the primary care network development. And then in the last year, I've been working with NHS England as one of the national clinical advisors, thinking about how we sustain and transform primary care as part of an integrated care system. And I really want to stress that you know, the new kid on the block as PCNs must be seen as part of the wider system. So this is all part of developing very strong foundations for our health system to change. So that's a bit about my background. Some key learning for me, because having been really at the sharp end of delivering services in some fairly challenged situations, and also starting to think through how I have developed my essentially primary care network locally, as well as being the integrated care system clinical lead, and starting to think about how we deliver care and how we talk about the same sort of concepts at an ICS level, across an integrated health and care partnership level, which is, you know, the next sort of size down in terms of population, and thinking about exactly the same transferable skills that you need to use at a primary care network level. There are a number of key learning areas for me. I think the first thing is the importance of developing trusting relationships. One of our ICS leads said once that change really only moves at the speed of trust, and I've never heard a more true statement really in my life. Getting back to basics, using all opportunities to develop those relationships, which we've really lost in terms of the primary secondary care divide over the last 20 years. We need to get back to the basics about using every opportunity we can, whether that's consultant GP Connect schemes, whether it's what we've done in Dorset, which is about taking our local leadership teams on a walking in the same direction leadership development, is incredibly important, because it starts to help us look through each other's lenses in terms of what's important to us in each of our different organisations, which then starts to break down that kind of that sovereignty that exists really in individual organisations, which we're trying to break down. And it starts to develop new relationships, so not just between doctors, but between the clinicians, but also our local authority partners, our voluntary sector, and also then starting to think about the patient voice as being critical in development of our local services. So it becomes something with increasing maturity that we can see increasing concentric circles, if you like, of the relationships that we build. And in its most mature sense, we would of course also be working with partners potentially in housing and education, and in fire and police, and so on and so forth. So we don't know each other, and it's really worth the investment. The second thing is that place-based leadership, I think, is all about influencing with and through others. So this is team-based, this is collaborative, it's distributed, it's non-hierarchical, and it's a totally different form of leadership from conventional organisational top-down leadership, and it's one that we should embrace. And naturally, particularly as clinicians, I think we're very used to developing these sort of relationships. We're good at that, into those interpersonal skills that help us to develop that. So this involves understanding the position of others, looking through each other's lens, and often means taking a step back to truly listen, active listening, and a willingness to adapt and review and gain consensus. And this is, as I've said, as true for the new primary care networks as it is about working with chief execs at an ICS or STP level. What's really important, I think, is developing a really clear narrative, a really clear vision, and taking time to do that at local levels, because each of our local geographies will look different, and we will each have a different priority to help us solve. And all I can say is that I've seen a richness of and desire to try and start to embrace some of the problems that we've never been able to tackle within the NHS by truly understanding our local population at its local level. So starting to address not just health outcomes, but thinking about health outcomes in the wider and in the context of some of the wider determinants of health. So all of this takes time and dedicated headspace. We can't do this on nothing or thin air. We need to create the opportunity and the environment culturally to be able to take this work forward, and regard it as just an important part of our day job, as the clinical work that we do, because without having time to deliver those services and think through the implications of what we're trying to do in terms of looking at either the data, service redesign, implementation, developing those relationships, it really won't work. And if you look internationally and nationally at best practice, you do see that developing the right environment for change and success is critical upon local leadership development. And what struck me in the last few years is that managers do tend to come and go, but clinicians really own their own services. And so it's really difficult to see that change in a sustainable and meaningful way will take place without very strong local clinical ownership and delivery. And so the clinicians owning and driving that change is a very powerful indicator for success. And then just finally, data is going to be critical to managing all of this. So really meaningful linked data sets, thinking about the use of population health management tools to detect our gaps, to help us provide a real basis for service redesign is going to be critically important, and one of the areas that I know that we will be looking to the future. And then just thinking about the what's next, what do we need to tackle next? I think embedding leadership at every stage of our careers, but starting to think about our new clinicians coming through, or in every area really. I think leadership needs to be embedded at the very early stage of the curriculums, and also to start thinking about how we influence multi-professional learning and development. So that leadership becomes truly embedded, and that teams really start to become really cohesive moving forward. And actually, there's nothing that is stronger really than that multi-professional learning together environment, thinking about our common challenges and thinking through new ways of delivering services that make the best of every pound that we have and make the best of everyone's particular skills and responsibilities.
Great, thanks, Karen. So just to pick up on a couple of questions that have come through, we will move sort of formally to the discussion afterwards, but thanks to Sarah Bainbridge, who said, I understand place is hard to define, but NHS England has been pretty clear that they're using place as somewhere between the system ICS and the neighbourhood PCN, and rather nicely just next to that, Fazana Hussain has written that there is no single definition of place. It depends on what your residents or citizens have. It's about leadership by all. So we're beginning to open the discussion here around whilst there is an NHS England sort of description of what place is, it's not quite so much about that. I think that's probably what we're beginning to hear. It's about what your citizens and what your residents sort of want and need, what their healthcare needs are, and then what their wider determinants of health are as well. I'm beginning to think about that as you are taking on the role of the clinical leader, of the clinical place-based leader. But we'll come back to some questions. So we're going to go off now to Dr. Mark Hamilton, who is going to tell us about his all about his journey around place-based clinical leadership. Mark.
Thank you, Sid, and good afternoon, everybody. I guess just on a personal level for me, I mean, my clinical role is an intensive care consultant, which seems a slightly odd space to launch into an integrated care discussion. But actually, I've had a long-term interest. My wife is a GP. And I've had a long-term interest in how integrated care can work better. So I spent about 4 years working in a clinical commissioning group in 2 different places. Spent some time working in community health as well. And I've been the clinical director of the Surrey Heartlands Academy really for almost the last 2 years or so now. And I think I've always believed passionately, as I think most of us do that work in these services or places, that it is always better to do things together, but often organisational boundaries, sovereignty and legislation does get in the way of that. So I think if I think about what we've done and what we've learned, I'd probably start in the same place as Karen. We spent a lot of time, I think, in the first 15, 18 months or so building system relationships and creating those kind of conditions that the leaders could flourish in. and we spent a long time with an organisational psychologist, understanding who we were for us to be able to get to know each other better so we could work together better. And I think the honest trip through that is that it created conflict at times, but it also gave us the space to work through the conflict. And actually we came up with 3 principles of those sessions. And the first one was that everybody in the group counts. The second one was that we can deal with conflict productively. And the third one was that the quality of our decisions matter. And it helped focus us back on things when times got a little bit tricky, and it gave a good framework to continue to have a discussion with. I think we started to look at how we could work beyond boundaries from the start of what we did. Place was only ever relevant to the citizen or patient for which it affected. So we had to be more through that lens. And one of the tenets of the academy that we put together was that it was able to work on the traditional places right from the very beginning, because it was of the system and for the system. And we recognized we had to provide a space for people to be able to connect, and also to small images, but also to support our leaders through that. So all of our work streams that we had also had a citizens ambassador with them, and we learnt a lot from local authority at that stage. We put together a citizens engagement program, building about 3,000 citizens on a panel that were genuinely demographically represented. So we wanted to really understand what place was. I think when you traditionally look at, particularly in the health sector, you can often get very professional people coming to give a view of the place or the system. So we went out and built it up from a very academic and demographic background that our local authority engagement teams did. And that was very effective for us to be able to put citizens in the places with the clinical leaders at the time, not only to co-design pathways, but also to influence and let people know what they wanted. So that the people that were leading those pieces of work in particular knew what was important for the citizens at the beginning. And then I think we also recognised that to be a leader in a system or a place, you needed support and you needed a team to be able to do that. So we very shamelessly stole some of the leadership wisdom from the Flyde Coast and created a Surrey 500 programme to allow teams of people, for up to about 500 of our leaders in the system, to go through and start to begin to understand how they would embed the right cultural conditions for teams to work together effectively at place. And it began to change our language about clinical at the time. And the more we worked together, particularly our local authority and colleagues, we were alienating to other colleagues. And I think where we landed was that multi-professional was a much better language. Recognizing that doctors are the traditional leaders in the health system, we very much mindful of all of our colleagues so that they felt welcome and they felt the ability to be able to lead wherever they could. And that was a very important learning point for us, was going through the discussion around the language. So we began to build some multi-professional reference panels whereby we bring our groups of different professions together that are interested in a particular either long-term disease process like cardiovascular disease, or looking really very specifically around prevention and the wider determinants of health. You know, we know in medicine, if we do everything we do very well, we still only tick about 20% of the social gap that we see across systems. So we had to be much more broad-minded than we were as a traditional healthcare setup. And if you look at place for us, we've divided what is nearly 850,000 population into 3 smaller segments, which are based on our traditional CCG boundaries, which we've called our integrated care partnership, hand in hand with our emerging primary care networks. And we learned a lot, I think, at the beginning in our partnership. And with the emergence of our integrated care partnerships, we're again learning again what genuine work means. So we've become the second devolved integrated care system in the UK at the moment, which has given us a different set of freedoms. But actually all of our work was done as a voluntary partnership at the beginning. And every change and influence we made was just through us getting our relational power pieces right, which meant that we often had to work much harder at those conversations. And that's been one of the key learning bits for me about multi-professional leadership, is that if you can't relate to the people and you can't build those connections across the system and across your traditional place-based care, you're always going to struggle to work at a system level. And I think it was one of Myron Rogers' maxims who said, when you want to build integrated care systems, or you want to build systems of work, you've got to continue to connect the system to more of itself on a daily basis. And I think Karen made the point earlier on that we've seen lots of people change in our system. And we had a point of reflection where we looked back at part of our senior leadership team, and about 30% of those have changed over 12 months or so. So you have to constantly reevaluate where you are, I think, as a leader in the system. And there's never any shortage of commentary on the right thing to do, but actually being able to facilitate a very part of the leader in the system, because you have to bring some consensus out of very diverse opinions. Time, I think we're all searching for data to be able to allow us to run genuine population health focuses. And I think we're all waiting for the answer on legislation. So I will leave legislation as my final point, Ted.
Great. Thanks very much, Mark. I know you're sitting inside an NHS organisation using the Wi-Fi, and your connection's a little bit scratchy, which makes me cry as a Chief Clinical Information Officer of an NHS organisation. But thank you very much. I'm sure that we got, I think we got pretty much everything from that. So don't forget that you can send us an email on hello@kaleidoscope.healthcare. You can send us a question through the questions tab in the GoToWebinar app, and you can tweet on hashtag PBCL, and we'll get hold of it. And we've just got Alex to do his talk, and then we'll be into the questions and the discussion. So can I hand over to you, Alex?
Hello, yes, so I'm going to just start again, as Mark has done, just to give you a little bit of context as to why a transplant physician should become interested in STP work. And that's really because in my lifetime working in transplantation, I could then see that integrated work that is working across specialties, medical, surgical, intensive care, that was absolutely crucial for getting best outcomes for individual patients. But secondly, and certainly very relevant in our local STP, transplantation is all about how best to allocate scarce resources. And the lessons we learnt from that, we think, are very resonant for how one should try to optimize what we do in an STP. So I've got a couple of slides. So if I can just have the first of the slides. We feel that for us, the main ingredients for clinical leadership, and I'm not so sure I'm absolutely wedded to the idea, to the name place-based, but the ingredients for us are that you need to try to inculcate a process whereby people can work and have the freedom to work across organisational boundaries, across disciplinary boundaries, and very importantly, we're quite a big geographic STP, to work across traditional geographic boundaries. And the way we've tried to do that is to promote centering all our conversations around individual patients and their needs, and around population health outcomes. So the two areas there are looking at both patient experience and having continuous feedback of how they are finding the process that we're going through. And secondly, what are the main drivers of our relatively poor health outcomes in our area, where we have some areas of significant health inequalities, and what are the long-term drivers for those. So those two things, patient experience and population health outcomes, by trying to address those and keep those as the main focus for all that we do, we found is the first step in trying to promote that clinical leadership. So if I just have the next slide, that's really what the STP is trying to do. And this is the slide tries to describe some of the how the STP is trying to do this. So we have a relatively big STP, it's about 1 million people, and we've found it easier to think through having clinical leadership at a number of different levels. So you need clinical leadership at the level of a primary care network. You need clinical leadership at what we call the alliance level. We have in our area one very big teaching hospital, that's Avonbrooks Hospital, and then another very big district general hospital in Peterborough. So we have sort of local alliances around those, which cover an area of about 500,000 people each. And then at the STP level, that's the whole population, we have promoted the development of what we call clinical communities. These are specialty based, but will increasingly become syndromic, in other words, deal with frailty, for instance, or multimorbidity. But I could give you one example of, for instance, our clinical community for diabetes, which involves patient voluntary organisations and charities, primary care, community care, secondary care, mental health, and most importantly, local authorities. So we try to get all the people in the room together and think through a 5-year strategy. That strategy will have a number of components, and we think one of the best ways of getting people to demonstrate this place-based clinical leadership is that process of working through and thinking through from other people's perspective what is best for your patient with diabetes. So for the patient with type 2 diabetes, not just thinking about it from the perspective of secondary care or indeed just primary care, but thinking from the perspective of local authorities and what we can do to prevent the various drivers that we know of obesity and type 2 diabetes. That process, we think, will largely help foster some of the behaviours which you'll need for place-based leadership. If I sort of think through some of the things I've learned, it would be firstly that structures, I do think, like communities, are important, but they're only so important because, as I think both of the previous speakers have emphasised, it's all about developing relationships and trying to put yourself in other people's shoes. And indeed, doctors, which, and I know, speak for myself here now, I mean, who are not very good at putting ourselves in the shoes of patients even, as to what is important for them rather than what's important for our organisation. That's the first thing, trying to think through in how it is for other people. The second thing is that we do need to be sure that we try to engender an approach where what we're aiming for is to improve both the patient experience and population health outcomes. If we keep those in mind, then we find that that is a good way of trying to prevent major disagreements and trying to focus and concentrate on the ultimate objectives of the STP that I mentioned at the beginning. And just to sort of wrap up, I mean, the things that we still are struggling with, and I emphasize that, you know, we in Cambridgeshire and Peterborough are, I think, one of the most financially challenged health economies in England. So we have major problems, but some of the biggest challenges clinically that we are still struggling with is how to address the whole issue of clinical governance and responsibility for system-based working rather than the old, dare I say it, GMC and CQC style of both individual and organisations being responsible for outcomes. We have got to get to a system whereby systems can be responsible for outcomes, rather, and that's the nub of the place-based leadership. So I'll leave it at that, I think.
Thanks very much, Alex. That's great. There are some brilliant questions coming out just in my head. Certainly those around the governance, and Karen, you mentioned that as well. So perhaps we can ask you in a second around governance and what you think about that. And then Mark, I'm going to ask you a little bit about the 500 system leaders that you put through a program, and that's a large number of people, and how you came around the idea of 500 and why you chose 500 and why and how you got the resources to put those people through, and what benefit you think that your place got from that large investment in clinical leadership. But I was going to ask you, Alex, to just kick off on that thought around the clinical leadership at different levels. I noted what you said about place, and I think you're right that I don't think we should get into to defining place as a number of people, but we do. I think we can probably all agree it's a patient in a place, or in a wherever they're living. It's a patient and what healthcare needs they have. But you then talked about the clinical leadership at different levels, and I just wonder whether those different leaders at different levels need different skills, and what your experience of that is.
I think there are some generic skills that people need, because to come back to everything that we've all been saying, it's about relationships. It's about face-to-face human relationships and how you work with people around a table to get an optimum outcome. And that is crucial whether you are a clinical leader of a primary care network or whether you're a clinical leader within an alliance. It's the same human interaction that is crucial. So that's the core of how you do it. I think you do, as you go to these different sizes, need a different focus on the importance of what are the outcomes you're trying to address. So I think those will clearly be very different at a PCN level as opposed to an STP level. But I would try to emphasize that, in my view, the core skill that everybody needs is the same. It's the human one.
Yes, yeah. We've all spoken about relationship building as being core to this, to being a leader, I suppose, but also to this endeavour that's perhaps outside the traditional hierarchical pyramidal shape that we're perhaps a little bit more used to as well. So Karen, thinking about the governance. I know we were discussing just before the webinar started properly about governance. I was saying that we don't want to get too bogged down in the governance so that it stops people working and stops these relationships developing. But at the same time, at some point we're going to be probably measured from a place-based geography, and we're also going to potentially be inspected as well from any kind of GMC or CQC or that kind of thing as well. So how do we keep governance well under control and make it useful for us?
So I think the saying about function, putting the function of what you're trying to do first is a really key and important one. I'm just going to try and link also a little bit to what Alex has just said, because what was really interesting for me as a clinical lead of an ICS, thinking about how I was linking with other clinical leads in the other systems in the first 2 to 3 years of our development was that we were all having the same sort of ideas about what should happen at an ICS level, what should happen in the geographies before that makes sense. Because so around a particular geography, maybe around a single acute hospital, which is at the heart of a community, and thinking about the community and mental health services that wrap around that, and now the PCNs that will be part of that, the wider grouping around that, and how we need to link through the primary care network, the clinical directors into the integrated health and care partnerships, these around 300,000 to 500,000 population sizes, and then thinking about what their place is in relation to the wider STP partnerships and ICSs is really important. And we've all come to it across the country independently, but come to the same sort of view that that's what really makes sense to populations of people. And then, as Alex is then starting to bring through the population data that helps us think about what's the health of that local population, and then the management of the gaps and the inequalities that have developed within those different populations at 300,000 to 500,000. Then you can drill down into the PCN size. And I know in my local area, 2 roads apart have got a 10-year gap in life expectancy. So you start to be able to see that the priorities can be filtered, or there's a golden thread that runs through in terms of population health data that tells us that. So I very much think about this idea about concentrate on what is the function that you are trying to deliver at each of those levels, and then you'll start to wrap the governance around that, because at some level there needs to be responsibility and accountability and role definition about who is holding that responsibility. But to me, that's very much a shared responsibility between all the partners within the network, or within the integrated health and care partnerships, and indeed within the integrated care system board, or your STP board, as you move to becoming an integrated care system, because we know that the ambition is that everyone will move to an ICS sort of development. But it is really important that at some stage, as I said, that we do start to think about what is the governance, where is the responsibility, where is the accountability, who is owning the data, and who is then starting to drive some of those improvements, and how can we make sure that instead of having a pepper pot of all different priorities, that we actually are focusing on our efforts on the things that truly matter to that local population. And so I think where I've seen this mature process developing, it hasn't been with a top-down approach of saying, this is how it should look, this is the board you need to have. It's been very much an organic, bottom-up growth that makes sense to those local boards, that makes sense to those place-based population size, as I've said, those integrated health and care partnership boards, and then to the ICS board. And we're seeing clinical representation at every level start to develop through, with the threads and continuity between all of them. So it becomes a vertical and a horizontal kind of distribution of that clinical responsibility within each of those places, but they are joined together. So we have not just individual networks, we've got networks of networks aligning themselves around in their natural local geographies, and we put in place then the structures and governance that make that work. And then we need to work with our partners in terms of CQC and the GMC and all of those other things that are really difficult. We need them to be part of the solution of how do we get through working across boundaries in a truly seamless way, so that we're not stuck and wedded to each of our own processes within the organisations. And that for me is really taking the next step in maturity.
So Mark, I'm going to come back to you and ask you about the 500 system leaders and why you made that decision, and sort of the not just the number, but the sort of the benefit that you hope to gain. And just the questions that are coming through from cyberspace is that, and we've all mentioned this thing about relationship building, and quite a lot of leadership development is around how to develop relationships with different types of people, and with people who aren't your type, or who come from different backgrounds. Just tell me, with regards to the 500 system leaders that you put through the program, how much time did you put into relationship building with those 500 people, and what was the expectation of them to go out and build their relationships in your system?
Thank you, Ted. Well, hopefully the connection will be a little bit more stable. So we've only launched the program last month, so it's difficult for us to evaluate the impact on it, but I can certainly talk you through the principles of how it came about. I think we felt we wanted to achieve quicker and bigger change. And unless we were going to bring people together in their communities and get them to understand what being a system leader was all about and what that meant for them in their community, we were always going to be chipping away on the edges of moving us forward as a system. So we took the approach, and the 500 really came from, as all these things do, was a little calculation on the back of a piece of scrap paper. If we took 100 people from each of our 3 integrated care partnerships, so we've taken the first 100 through from one of our integrated care partnerships, and we've taken another 100 through from our children, families and schools team as well. And then we looked at 100 of those people that were working in and around the borders of where we were. We could begin then to build the relationships locally. And because they were all going through the same program, and we've included about 6 days of development in that program with them, they would all be co-designing half of their system leadership course. So it was very relevant to them at place, but also that they would understand the principles of working together across the system for the benefit of the system, not just from within their local organisation. So we asked for a nomination process from all of our different providers within each part of our system, so that we could build people that were demographically represented for place, not just from a single space.
I think we might have lost you there, Mark.
Where did you leave me?
No, don't worry. Let me just ask Alex and Karen about a question that's come through around the time that it took you to break down those organisational barriers, and that's a bit of a piece of string type question. I'm sorry for that, but sort of in general, where did you feel like you probably never felt like you actually have broken them down, but where did you feel like you met a critical mass in breaking down organisational barriers? Alex, let's start with you, if that's okay.
No, this takes a significant amount of time. I think it helps if you can try to, as I think Mark was implying there, start by selecting people who come from the right place, as it were, rather than the backwoodsmen, if I can call them that, who may be very, very difficult to persuade. So start with the enthusiasts who sort of get the process. And I think this takes over a year to start to mature. That would be my view. One of the difficulties of that immediately is that, particularly in, shall I say, challenged health economies, that people do need an investment which won't immediately transform outcomes immediately within the same financial year. That's not something that reads very easily with NHS England or NHS Improvement, if I can be blunt, who want it yesterday. So you do need to be allowed space and time to, and if you're trying to do all this under the sense of pressure, it's got to be done by tomorrow, then that is a positive disincentive to allow a mature relationship to form.
Yeah, what about you, Karen?
Yes, and I'd completely agree. Whether it's leading at ICS level or at ECN level, it still takes, I'd say, 1 to 2 years really to start to feel like you're anywhere near maturity in terms of what we're trying to achieve. And there's no easy way around that. There's no quick solution. You can't shortcut that, actually, because it is totally dependent on the relationships that you're forming, and actually then some of the difficult decisions that then you're taking collectively, which then of course then enhance your maturity going together. So there is something about, you know, being able to confront some of the really tricky things that you're trying to solve together and actually work through common solutions that then enable you to move to that step of maturity. And my other reflection about the challenges within the system is whether you're in a hospital or whether you're in a general practice, you know, we are all challenged in a different way. We all have collective problems. So then sometimes some of the solutions are around thinking about the collective solutions to go forward with. There's a question from Fazana about how do you put that time in when you're trying to do the day job as well effectively in terms of the delivery of the contract, the new roles that are coming in, and of course you have to do that. But it's about realizing the investment of time that then enables you to move much more quickly then on when you've got your vision, you've got your clear narrative, you understand what each person does within your local system, and then people start taking that responsibility. And I you know, I can't emphasize enough the richness and power of being able to have those sort of mature conversations that then people are very happy to step in and take that part within the system. So it's not, so it doesn't become one person having to drive at all.
So you think it's about holding your nerve for a little bit of time?
Hold your nerve, absolutely. Thank you.
How long do you think you had to hold your nerve, Alex?
Well, I mean, I absolutely agree with that. There's one other point I'd just like to emphasize, and that is trying to think through at an early stage because all systems have big problems. And there is always a debate at the outset as to whether you should try to address the biggest problems first or go for some easy problems first, you know, to give you confidence. And I don't have an answer to that, because I think it depends, you know, on the individual circumstances. But do think through carefully which problem you go for first, and don't necessarily just go for the easiest first, because sometimes it's the journey traveled together that is the development, and tackling a really big issue sometimes can be really sort of useful and creative for bringing relationships to a different place.
Yeah, oh, thank you. Mark, I'm just thinking with the development of the academy, one of the questions has come from Mary Parfitt, and she has asked us, how is success being measured and demonstrated? I'm just wondering, you've probably got some metrics around that for the academy. Can you tell us a little bit about that?
So I think one of the challenges about evaluating anything, as I think as Karen and Alex have said, is that much of our success is qualitative. So for us to build those better relationships, that's hugely important. Some of the work streams that we have been working with, some of them have delivered really good examples of change and some great pieces of transformation. But most importantly, it's continued to connect the system together again. And we've been able to bring in quite a lot of principles around using quality improvement as the real change agent to get people to focus on what needs to be done, and bringing people together to build the consensus around those programs of work. It's been a hugely important part of what we've done, because we know that those face-to-face connections are so important. It's so easy for us to pick up a phone across the system or not put the shoe leather in that we need to go and meet people. So we have a series of big meetings 3 times a year, which we call Connect, just to bring together different people that wouldn't normally collect across the system. That's been very powerful for us. And just to give you another example of using data, we managed to create a authority so that we are all focused on the same data, that we know that they are completely aligned to our system ambitions, which has been a really important step for us.
Yeah, that's great. Karen, you had something to add?
Yeah, so thank you. So I think the other thing in terms of how would you measure and demonstrate success, of course, you know, there's the patient satisfaction element, which is really important. But I think we need to also think about our workforce satisfaction. So one of my priorities is making this NHS system, health and care system, a better place for people to work and want to come to work. And there are so many passionate and devoted people who work within the NHS who should be recognised the value should be recognised, but actually I think that by doing things in a different way, we are starting to see that the workforce actually are feeling like this is a better place to work, and to come to work not holding the burden on their own, but feeling that they're very much part of a multi-professional team. And I think that's really critically important. So if we could start to think about embedding some sort of satisfaction around patient, but also workforce, as well as some of the outcome metrics that we're trying to achieve, I think would be in a really good place.
Yeah, no, I'd agree. It's certainly the work that we've done with Kaleidoscope, and also I did with Kaiser Permanente was around what makes clinicians have a good day, and teams was being, was always the first thing that anyone mentioned. So don't forget, we've got a few minutes left, but you've still got time to pop us a question. You can do that by emailing us on hello@kaleidoscope.healthcare via the question tab in the webinar app, or on Twitter, #PBCL. So we've had a question around multi-professional leadership, and whether we shouldn't be talking about clinical leadership anymore, but actually be talking about multi-professional leadership. There was a little bit of a Twitter discussion on the way on the train for me this morning around that, and I must say I was thinking with probably clinical leadership is part of multi-professional leadership, but what do you think, Karen?
Absolutely, that's definitely, as we mature the way we're working. So in my clinical reference group or clinical senate, we have not only the medical directors, we have GPs, we have directors of nursing, but we also have allied health professional lead, and we've also got a pharmacy lead now coming to the fore. So I think we're just starting to beginning the journey, and as clinicians we need to embrace that and make sure that we are not the only people in the room. There are many people with huge skill sets who are very complementary to our system, and we need to acknowledge them and give them their place within that, at that leadership table at whatever level.
Yeah, so multi-professional, I think clinical begins to have that connotations of medical, and but perhaps that's what we're all trying to avoid. Alex, would you agree?
I'd strongly support that. That's what I mean. I think I mentioned. I'm not so happy with the place-based clinical leadership. I don't think is right. It is, as you say, it is leadership, and it's difficult to find an easy adjective to go in front of leadership that embraces everybody. And I would, from what Karen said, I would also include local authorities, social services. I mean, they're absolutely critical. So the people who become, we certainly have chairs of our care communities, but I mean they, in our view, should come from all and every sectors that are involved in the whole endeavour. Yeah, crucial.
Thank you. Mark, a question that's just come in says, in your experience, how important is focusing on strategic goals on gaining quick wins early? So I think what we're asking is, and Alex mentioned it as well, is what's the balance between the quick win as a place or a system versus the more strategic level goal? What's been your experience, and how have you balanced those two?
I don't think you can have one without the other. You've got to demonstrate change through success, and that's got to be something people can see and feel in the short term. But you've also got to hang that off a strategy that makes sense for a direction of travel. And I think having those two for us has been crucially important.
Yeah. Yes. It's without having the two up against each other, it's difficult to know sort of which ones you choose, isn't it? So I'm going to think about asking our three panelists to reflect on what they've heard today, and just give us a couple of sentences on what you've said yourselves and what you've heard other people say, and also on the questions and the answers that we've given. And I'll start with you, Karen.
Thank you. So I think the first thing for me is there's real commonality in what we've all said. We're all from very different parts of the country, all from a different place in terms of our leadership and our systems, but there's huge commonality, and this is a very credible way of taking things forward. I think the second thing is that we mustn't forget the patient's voice in all of this. Patients can also be our biggest ambassadors for change as well. And the third is this having a really clear view on the clinical outcomes and the gaps, and to start reducing some of the inequalities that are occurring within our system, but with a view on the wider determinants of health that count for so much in terms of health improvements.
Thank you very much. Mark.
I agree with Karen. I think we all are coming from very similar spaces. And I think my one lasting message to everyone is it is all about relationships. You can never listen to your patients and citizens enough, and you have to constantly go back and take the temperature of that because things change. Dealing with unwarranted variation is more complicated, but it's got to be an incessant focus if you generally want to build a space that people want to live and work in. And you have to come back, I think, very regularly to what you're doing and see whether it's effective and see whether you're creating the right conditions for people to want to live and work there. It's really important.
Yeah, great. And Alex?
Well, I think one thing which I think we haven't quite touched on, which I think I would keep emphasising as important, certainly in our area, is the relationship between your STP and health and wellbeing boards, and involving them in the whole process. That in itself is a very difficult one. They are democratically responsible, but which is something that STPs aren't, and making sure you get that relationship right with your local authority is absolutely crucial for us for what we do together. But you're right, we've all been saying much the same thing in our own different ways, that it comes down to, you know, a form of distributive clinical leadership that is going to help solve the strategic aims that we need in order to improve population health.
Great, thank you very much. Well, it's 2 o'clock. Thanks very much for joining us. My thanks to Alex and Karen and Mark for both their presentations and for their brilliant answering of the questions that we've had from you, the listeners. We will sign off and say thank you for listening to our webinar on place-based clinical leadership. Thank you.